It is also an excellent element for prognosis of sarcoidosis. Is there any questions in the audience? No question? The audience is calm. Too calm. You can.
Thank you, Dr. Ramos. I present a case of a 37-year-old man with a past medical history of acute rheumatism articular, complicated by aortic stenosis and regurgitation with a later regurgitation without a history of fever. He presented to our consultation for a sudden, complete and painless vision loss of the left eye 1 week before the consultation. And our examination found a good visual acuity in the right eye without abnormalities of the anterior segments, without neovascularization, and the dilated fundus exam in the right eye was normal without any abnormalities with a normal arterial tree. But in the left eye, the visual acuity was reduced to counting finger with enormous segment, anterior segment without neovascularization, and the dilated fundus exam in the left eye showed, like we see here, a white ischemic retinal edema with a cherry red spot and a papilla edema without anterior emboli, without vasculitis, no retinopathy, and no retinal hemorrhage, nor retinal neovascularization. When we do the fluorescent angiography in the left eye, we don't find a delay in the arterial nor choroidal filling, no retinal ischemia, no abnormalities in the blood column, no vascular staining, but we see here a minimum hyperfluorescence of the optic disc. The fluorescent angiography of the right eye is without any abnormalities. The diagnosis was easy, and it is a central retinal artery occlusion of the left eye with a spontaneous reperfusion. But the problem here is such a blinding affection affected a young man with a history of valvulopathy. So we are faced on a vital emergency, and we ask for cardiovascular exam with echocardiography, which shows, like we see here, a mobile mitral vegetation sized at about 12 millimeters, and another aortic vegetation here superior than 15 millimeters. So the diagnosis was infective endocarditis complicated by central retinal artery occlusion, and the management was an emergency admittance in the cardiology department. Blood cultures were done and isolated staphylococci, cerebral and thoraco-abdominal MRI, projectile with no other systemic emboli, and the patient received antibiotics. Heart surgery with aortic and mitral valve replacement was proposed but refused by the patient. And for the eye, we will do an ophthalmic exam every 1 or 2 weeks, then monthly. So a central retinal artery occlusion is a rare but blinding disorder. The diagnosis is easy, and in the early stage we can have this retinal white opacity of the posterior pole with a cherry red spot, cotton tracking, and rarely we can observe intra-arterial emboli. In the later stage, we can find retinal arterial attenuation with the macular retinal pigment. Fluorescent angiography showed delayed filling of affected vessels. But the problem, one of the problems with this pathology is the cause. It may be caused by hypercoagulability states on thrombi, but the most common cause is the emboli, which come usually from carotid arteries, but also rarely from the heart. And when emboli comes from the heart, there may be a tumor, arterial fibrillation, and it may be due to an infective endocarditis. And embolic complication of the infective endocarditis occur often when we have a big vegetation size, a mitral valve endocarditis, and a staphylococcal endocarditis, and all these risk factors were present in our patients. Other ocular manifestations of endocarditis are a conjunctival hemorrhage, rough spots, which are white central retinal hemorrhage, chorioretinitis, conjunctivitis, a branch artery retinal occlusion, and ophthalmic artery occlusion. occlusion and the central retinal artery occlusion. But what about the management? We retain that the central retinal artery occlusion is an emergency. It's the equivalent of a cerebral stroke, so the management must begin immediately after clinical diagnosis, and given that occlusions more than 4 to 6 hours produce a massive and irreversible retinal damage. The proper management of central retinal artery occlusion due to infective endocarditis doesn't differ from management of this affection due to other origins. We must target acute reperfusion of central retinal artery mainly by inhalation of Digogen, ocular massage, blood compression, and recently there is a little interest in the use of tissue plasminogen activator, but there are no current guidelines endorsed therapies. And secondly, we must prevent of ocular neovascularization by a laser in the retinal ischemia. To conclude, we must retain that central retinal artery occlusion due to infective endocarditis is uncommon but potential blinding complication of a potentially mortal condition. And you must think about infective endocarditis when we have a central retinal artery occlusion in young people, even without a history of valvulopathy and even without fever. Such affection requires high medical reflexes and a good cooperation between ophthalmologists and cardiologists. Thank you.
Thank you, Dr. for
Thank you.
Dr. Lash. Congenital retinal microvessel and retinal cavernous angioma, about what it is.
Thank you for this opportunity to present in front of this audience. Our case is above 59 years old patient who has a medical history of hypertension and diabetes. She's also treated for primary autoimmune glaucoma since 2011. This patient is reporting decreased vision in her right eye for over 10 years. The ophthalmic examination of the patient shows visual acuity in the right eye of 210, a central corneal epithelial opacity. The anterior chamber was deep crown, EOD was 14, and she had corticonuclear cataract, N1C1 on the street. The fundus examination shows a diffuse cluster of saccular dilatation localized on the macular regions. These saccular dilatations are on the course of an aberrant macular vessel, which is originating from the inferior and temporal vein. This macro vessel crosses the macular region at the median ravule. There is also an intraretinal hemorrhage located superior and temporal to the fovea. The examination of the left eye found a visual acuity of 610, the central corneal epithelial opacity, anterior chamber was deep and crown, EOP was normal, and lens has a corticonuclear cataract C2, and the fundus examination of the left eye was strictly normal. There are no signs of diabetic retinopathy. So fluorescein angiography was performed. It shows an early filling of the aberrant vessel, and we can see that the saccular dilatations become hyperfluorescent saccular caps, and this hyperfluorescence is maintained throughout the late phases. We can also see the masking effect due to the intraretinal hemorrhage. We can also observe an abnormal visibility and dilatations of the choroidal vessel. The angiography of the left eye was normal, periphery also was normal. So an OCT was performed. The OCT in the right eye shows preserved foveal profile, hyperreflectivity on the surface of the retina with shadow growth due to the presence of the aberrant vessel. There is also hyperreflectivity inside the retina due to the presence of these acutes, and also we can see an elevation and an irregular elevation of the IPE. This is the second image of the right eye. It shows the hyperreflectivity of the aberrant vessel going through the fovea, near the foveal central region. The OCT in the left eye was strictly normal. So the study reached the diagnosis of a retinal cavernous hemangioma associated with the congenital retinal macrovessel. The follow-up of this patient, the general examination disclosed no abnormal neurological signs and no cutaneous angioma. The cerebral MRI discarded the presence of other associated vascular abnormalities, and ICG angiography is yet to be performed. After 4 months of follow-up, visual acuity remained stable, and the intraretinal hemorrhage, you can see it cleared out spontaneously. The cavernous hemangioma is a congenital vascular hematoma probably present at birth. It is more commonly seen in female patients and usually unilateral. It may occur in a familial pattern and can be associated with intracranial and cutaneous vascular hematomas. This lesion is composed of a dark blood-filled intraretinal aneurysm restricted to the retina or the optic nerve head with a characteristic cluster of gray appearance and variable degrees of gliosis and fibrosis. The fluorescein angiography has a characteristic picture. It shows that the sacral lesion fills solely during the venous phase and then become hyperfluorescent sacral caps. These sacral caps, this hyperfluorescence is maintained throughout the late phase and the lesion do not leak. The OCT can show the presence of saccules. There are no leaks and we can observe surface gliosis and sometimes epiretinal membrane. This lesion requires no active treatment. It rarely increases in size and may undergo spontaneous thrombosis and then develop increased gliosis. It may bleed into the vitreous and then it can need a laser or cryotherapy to treat the tumor. The second pathology this patient has is a congenital retinal macrovessel, which is a rare, usually unilateral retinal vascular abnormality of unknown acute pathogen. A large aberrant retinal vessel is present in the posterior wall and even may cross the foveal region. The fluorescein angiography shows an early filling and delayed evacuation of this aberrant vessel. It can also show a delayed capillary bed, capillary non-perfusion, foveal cyst, leaks, wall alteration, and associated arteriovenous communications. Usually, this macrovessel is stable and visual prognosis is excellent, but if we have a visual impairment, it can be due to macular hemorrhage, foveal cyst, serious macular detachment, or if the course of the vessel itself is through the foveal avascular zone. Thank you for your
We reported the case, two sisters and one brother, aged between 59 and 71 years. They were referred by family physicians and neurologists for an acquired ptosis assessment. These are our patients. What can you see on these photographies?
Please stay close to me.
Sorry, what can you see on these photographies? Okay. So, in our patient, we found almost similar characteristics. It's an acquired and progressive one, non-variable on the day. It's bilateral, symmetrical, similarly which impeded the visual axis. It is associated with an alteration of the levator function, and we see an overaction of the frontal muscle. Which important clinical sign should you look for? And it will be very helpful in both diagnosis and decision making. We evaluate the oculometricity of our patient. We found a limitation of the elevation, a paralysis of other eye movements, and the poor Bell's phenomenon. This accurate oculometricity may lead to an ophthalmoplegia, and the association between this drooping eyelids and the motionless eye, we can see here the exotropia. This is what we call the Hutchinson facies. This Hutchinson facies is very evocative of our diagnosis. So what clinical diagnosis are you thinking of? Yes. It's a form of progressive ptosis. Okay, so we thought about myopathic ptosis. And we do the muscular biopsy to corroborate our clinical diagnosis. We found red ragged fibers with accumulation of mitochondria, and the anatomopathologist need to complete with immunohistochemistry to make the distinction between different diseases, and they conclude to chronic progressive external ophthalmoplegia. So now in general, the myopathic ptosis is a primitive dystrophy of the levator muscle of the upper eyelid. When it is associated to an ophthalmoplegia, we call it the ocular myopathy. It is often a late diagnosis and a false one because of clinical polymorphism. You should always make the difference between other diagnoses of the progressive form of ptosis, like aponeurotic, neurogenic, traumatic, or mechanical cause of this ptosis. So to make your diagnosis, you need first of all to search for family history. These are 3 families that they are followed in our department. Then you need to evaluate the clinical characteristic of the ptosis, that you can remember that it's severe, bilateral, symmetrical, and they are always associated to an ophthalmoplegia. Don't forget, it's attachment with fishes. And to confirm a diagnosis, you need to make a biopsy of deltoid muscle or of the levator muscle, and then you complete with the histochemistry or the genetic study, because this myopathic, we can find it in different pathologies like mitochondrial myopathies, and we can say that the chronic progressive external ophthalmoplegia is the most frequent one. Then there is the oculopharyngeal muscular dystrophy or the myotonic dystrophy. Just a little word about the management, which is very difficult. In this pathology, we only intend to clear the visual axis, and the procedure of choice for the correction of ptosis is still controversial. Some surgeons choose to make the levator resection, like we did in our patient. Others choose to make the frontalis suspension surgery because they evaluate that the muscle is useless. The success rate of this surgery increases in patients with higher levator function. Two complications are very frequent in this pathology. And first of all, you need to inform your patient about the risk of recurrence even after a good result of the surgery. And then you have to correct your patient with a voluntary undercorrection, because due to the absence of that phenomenon of oculomotor problems, you have a big risk of keratopathy. And you need to systematically treat your patient by artificial eye drops and ointments.